So this is part 2 of the body's innate response. And I have a picture on the screen that shows here you got a splinter and what would happen. And the first thing we have, if you're following along with the notes that I've provided with to go with this, it talks about the 4 characteristics to the inflammatory response. So if the second you get the bee sting or the splinter or even just a small cut, so there's going to be redness there, and that's actually as a response for chemicals being flooded to that area. We want that to happen. We need the histamines to be there. And then there is also going to be a slight change in temperature because we're going to have a manufacturing going on in that area. So there'll be some prostaglandins that are added in that area, and that causes that manufacturing or a small amount of heat. And there'll also be swelling because the blood vessels, in response to this, in part of the healing process, they're going to need to go through some dilation. And then, of course, all of these things are going to cause some pain. You get the pain from the swelling, and it's actually, you don't think about swelling causing pain, but anytime any of you have had an ankle roll or a small injury, they'll tell you to ice it. Well, the ice is on purpose trying to slow down the blood flow from capillaries because that will cause swelling, and swelling causes pain. But the swelling does do a few good things. It helps dilute anything that's harmful in there. So if you're looking at the picture I have on the screen, they're showing you that the bacteria got in from the skin or from the splinter or the nail, whatever else that is there. And so the swelling actually helps dilute some of that bacteria because it's bringing a supply of other chemicals into there. It also brings in oxygen. And then on top of that, you may have heard about clotting factors. So when we talked about back in the cardiac system, I discussed platelets. And so platelets are what we know causes the clogs for a small little cut. And so platelets should not be sticky. In fact, one of you did a disorder where a person was born with the platelets always sticky, and that generally does not end very well. The person usually suffers death quite early on in life because what happens is that they're constantly sticking and they're clogging up the arteries and the veins, etc. So many of you may have a relative that is on a warfarin or a Coumadin, and those are both medications that they talk about thinning blood, but that's not what they really do. What they do is they stop the platelets from getting sticky. And that's why these individuals have to be very careful when they get the small amounts of bangs or bumps. The students that would have been doing their clinicals at the nursing homes would have noticed that a lot of the older patients have a lot of bruising. And that is because they're on the medicines that keep those platelets from getting sticky, trying to prevent another stroke or a heart attack. So that number one thing, if you're looking at the notes I've done for you, is the 4 parts of the inflammatory response are redness, heat, swelling, and pain. And then we would have phagocytes mobilizing into that area. And you can see that on the screen that we have that the phagocytes are engulfing some of the bacteria already here. And so a couple things happen to get that phagocytic mobilization. Chemiotaxis, which are inflammatory chemicals, and they help attract neutrophils, and neutrophils are one of your white blood cells, and we need them there. So that's one of the things that once the injury has happened and all of these little responses happen, it encourages the phagocytes to come to that area and the neutrophils to come to that area. And we also have leukocytosis, and that's the neutrophils from the bone marrow. They're one of your types of white blood cells will be coming out of that bone marrow. Again, they would have received a signal, and if you're in that AP group, we're always talking about cell signaling, where one command goes and then signals something else, another response. And that's once the injury happens, the bone marrow is given a message that says that it needs leukocytosis or the neutrophils to go to that area. And then we also have margination, and you'll hear about margins in a couple different ways in medicine. In this case, the marginization, neutrophils cling to the walls of the capillaries. So I told you that we didn't want all platelets always being sticky. But in this case, especially where you have margins here, we want the neutrophils to start clinging here, and then they would help the platelets also cling. So we're needing both of those factors to happen at the same time. We want marginization. We want an area clogging up with both the white blood cells and with the platelets. And remember, in our first video, I had a discussion about when you see pus, people are always upset about that, and all pus is white blood cells. So it's not the pus that's the problem. The problem is that it's there as a response. Phagocytes are not able to engulf all of the bacteria, so they're sending neutrophils in there as well. It just it informs you that you have a little bit more bacteria in that area than you want, and that's generally when the wound would be cleaned out, secondary, where it would be an ablation where any kind of dead tissue would be removed, etc. And so besides the phagocytic mobilization, in that you have also 4 things happening. You have the chemotaxis, where inflammatory chemicals are in there, the histamines are in there, and they're encouraging neutrophils, and neutrophils are being released from the bone marrow, and they'll go to that area. And then the marginization happens, where the neutrophils are going to start clinging to the edges of the wound. And then they end up squeezing the capillary walls, and as they squeeze those capillary walls, they help the platelets cling even a little bit more, and that's what is stopping a lot of your injured area. And so that's why when a person has a bad cut, they'll always say apply pressure, because you're trying to help the neutrophils in their marginization, and you're also trying to help the platelets move out of that capillary area and to help seal the wound, because the platelets have got to make it from the blood vessels into wherever that wound is. And so those are our big last 2 pieces for our response, our innate response. So our inflammatory response, where we have 4 things: redness from the flow of chemicals. We have heat from the prostaglandins, and they're necessary there. And again, we only want a small warmth. We don't want if it starts to feel warm to the touch, that usually means that there is an infection that's under the surface that's a little bit larger than we want. And you're going to have swelling from the histamines helping there, causing blood vessel dilation. And you're going to have pain from this swelling. But that swelling is not necessarily a bad thing. We just want some of it because it helps dilute the harmful bacteria. It gives it a bigger area for the bacteria to be in. And it also encourages more oxygen in that area, which again is good, and clotting factors will go. So the last thing I want to talk about today is fevers. So they end up being as a component of something, us having a bacterial or a viral infection, or fungal even instead. And remember, I've discussed that fevers are not necessarily bad, because remember, that's the amping up of our manufacturing of our white blood cells and all of these other responses that we're trying to get to a wound. So one of the big things with the fever is that pyrogens are released from the leukocytes and the macrophages are there, and you can even see here, again, histamines are causing swelling to occur. And that fever does 2 good things. Number one, if the bacteria has proteins in it, it can denature that, and it also increases the metabolic rate of all of these things that we're seeing that we want our body to do. The bad part of the fever is if it gets too high, it does start denaturing proteins that we need. So it's that threshold of below 103 that we want the fever to be going. So that's one of those things you try to talk a parent into letting a fever go a little bit, as long as it doesn't get high, so that actually the child's will get over, if they have a bacterial infection, they'll actually get over it quicker. So Tylenol is there, but you want to put it on hold until you really need to use that Tylenol to reduce the fever. If you take a good look at the picture, and again, I've included this picture in your notes for innate defenses number 2. Take a look at it's telling you that the damaged tissue here is actually sending out a release of the histamines. And so that goes into that blood flow area. And then the histamines are going to cause the capillaries to leak, releasing the phagocytes. And remember, the phagocytes are going to be there to help engulf the bacteria. So once the wound starts, the histamines are released. Histamines encourage the capillaries to leak, letting the phagocytes be released so that they can start engulfing that bacteria and other dead cells. Part of interesting now that we are seeing some evidence that young children with the coronavirus seem to be having a toxic shock syndrome effect, and that is probably because the body is doing such a high level of work of trying to get rid of as much of the virus, and we're getting toxic just material in there, and it's all flooding into the bloodstream at one time. So then once the phagocytes engulf that bacteria and the dead cells, we've got to get rid of them. So this picture doesn't show it, but the phagocytes would actually go to the edges of the epithelial tissue and would go through exocytosis, engulf it, and shove it out. And then the platelets move in finally, and they seal the capillaries. And again, that is when the platelets have gotten the command that they need to turn on their sticky surface, the nitrous oxide sticky surface. And again, that response will be much slower in the older patient or even a younger patient who has already suffered a stroke or is in risk of a stroke and is taking one of the many products on the market, warfarin or Coumadin, that stops the platelets from automatically becoming sticky and help clog a wound. So that's that greater risk that the older patient or the patient who's already suffered one stroke again has. So again, our last part of our inflammatory response has 4 parts, and then we have our phagocytosis mobilization also in there. And that is our end of innate part 2. And please, I would recommend highly taking the notes that I've given you and following along with the video and with the notes. Thank you.